Greetings and welcome to another Oral Pathology Tuesdays. One second. I seem to have a lot of feedback. Okay, sorted out. So it's nice to see you here. And today we have a very interesting topic that really, as many of you have voted and mentioned, is relevant to dental and medical practice. Because tobacco addiction is pretty much like any other chronic disease. And yes, it's a disease. It's because finally nobody gets up on one bright day and says, let me get myself a tobacco addiction. It's a disease. It just happens. And like many other things that are caused by bad or faulty lifestyle habits, well, it's the same way. It's caused by one. But eventually we need to help our patients and the public to get through it. And for that we have a very interesting session today with someone who is an expert on the topic. And we are very
And we are
happy to
very
have her
happy to
here,
have her here,
and that is
and
Dr.
that is
Aruna
Dr. Aruna
DS.
DS.
And
And
I'm sorry,
I'm
Aruna,
sorry,
I have
Aruna,
a
I
lot
have
of
a lot
feedback
of
from your
feedback
side.
from your side.
Okay.
Okay.
Anyway,
Anyway,
why don't you
why
just tell
don't you
everyone
just tell
about
everyone
yourself?
about yourself?
Yeah, good afternoon and warm welcome to everyone for this webinar. Dr. Aruna, a dental public health professional and a tobacco cessation specialist, is here to present a webinar titled Tobacco Cessation in the Dental Practice, a Bird's Eye View. So, like my focus of interest include the tobacco cessation, tobacco control, and oral cancer. And I would say that I utilize the many learning platform to upgrade my skills, which includes the Public Health Foundation of India, wherein I pursued my postgraduate diploma in health promotion with applied focus on tobacco control, and VKN NIMHANS, Indian Dental Association, I Can Care, and CIFR PGI Chandigarh, and NICPR ICMR, wherein I learned the skills of the tobacco cessation, both the smoking form, smokeless form, as well as the tobacco control. And I am an alumni of KLE, Institute of Dental Sciences, Belgaum, BDS, and MDS from SDM Dharwad. So I try to concise the things with a stipulated time period, whatever I had learned, and I would be happy to connect with you all further to the focus of my interest, that is tobacco cessation and control. If anyone of you are interested, thanks a lot, ma'am.
Thank you.
Thank
Thank you
you.
for
Thank you
sharing
for
that,
sharing that,
because there are
because there are
lots of
lots
people
of
who
people
no
who
doubt
no
would
doubt
like
would
to
like
hear
to
about.
hear about.
Sorry, I got to
Sorry, I
sort
got
this
to
out.
sort it out.
Let's see now.
Let's see now.
Okay. All right, let's just go to the lecture. I will sort this out by the time we come back.
Okay. I, Dr. Aruna DS, a dental public health professional and a tobacco cessation specialist currently residing at Bengaluru, express sincere gratitude to Oral Pathology 360 for giving me an opportunity to present this webinar titled Tobacco Cessation in the Dental Setting, a Bird's Eye View. The learning objectives include understanding of tobacco dependence, basic knowledge about the pathophysiology of nicotine addiction, what we can do and why should we do it, but how. 5 A's and 5 R's brief tobacco cessation protocol, the 5 A's model to help the patients who are ready to quit tobacco, and strategies for addressing the physical addiction so as to deal with the withdrawals and the cravings, pharmacological therapies, NRT and non-NRT medications, and strategies for addressing the emotional and the physiological psychological connections, strategies for dealing with the behavioral and social connections and the triggers management, relapse prevention, 5 hours model to increase motivation to quit tobacco, summary of the evidence and conclusion. Nicotine in tobacco, remember that it is the most lethal drug sold virtually at every street corner. So, nicotine, be it in the form of the smoking, or else the smokeless tobacco, or else in the vaping, it hijacks and rewires the neurotransmitter system in the brain. The most addictive drugs probably aren't the ones we usually think, but the nicotine is the most addictive drug as compared to the alcohol, marijuana, cocaine, and the heroin. So here, like the according to a study where the Institute of Medicine, like for those 76% of the population who had tried the tobacco, so the 24%, that is nearly 32% of them developed the dependence as compared to the other drugs, other substances like alcohol, marijuana, cocaine, and the heroin. So here, nicotine is considered to be the most common gateway drug apart from the alcohol and the marijuana. Then that is because it opens the nicotine use earlier at the age group, for usually during the adolescent the children. They are the most vulnerable one. It opens the gateway for the future addiction, be it the behavioral addiction or else the substance use disorders. So here, higher risk of the cocaine addiction among the people who began smoking cigarettes before starting the cocaine use is also reported. And the molecular basis for nicotine as a gateway drug is very much evident. So, what is nicotine addiction? It is a brain disease that drives changes in the brain and the behavior, and is not just a bad habit. And it is a chronic relapsing disorder, much along the lines of other chronic diseases like diabetes and hypertension, which often requires the repeated intervention and the multiple attempts to quit, because here the lapse and relapse is a part of the journey. And to treat the tobacco users effectively, the clinicians need to address the tobacco use with the patients consistently, and tobacco users need to be educated, supported, treated, and followed up. And tobacco users usually maintain the minimum serum concentration so as to handle the withdrawal symptoms, maintain the pleasure or the arousal, and to modulate their mood. And they titrate either by smoking more intensively, by dipping more frequently, and obstructive vents on the low nicotine brand cigarettes. So, smoking and quitting is also considered to be a part of the social and environment influence, and there is a relationship between the initiation and the continuation or the maintenance of the tobacco use among the young people, usually a range of the social and the environmental factors, and the home environment, peer influence, exposure of the tobacco industry, advertising and promotion. So these factors, they lead to the initiation as well as the maintenance of the tobacco use. So it is leading to its normalization of its use. The legislation that deformalizes the tobacco by making it less visible and less socially acceptable, such as advertising and promotion, is crucial in reducing the smoking or the tobacco use rates over time. So who is vulnerable? So there are factors which affects the genetics as well as the epigenetic factors. The genetic, it is the gene which loads the gun, but the environment which pulls the trigger. So however, for the adolescents or the childhood, they are considered to be the very much vulnerable because of the influence of the peer and the parents, behavioral problems, and the personality characteristics like the high risk taking behavior, externalizing behavior, as well as internalizing behavior, and the depression, anxiety, and the genetic influence. And the persons with the mental illness or substance use disorders, they share the shared general genetic predisposition, so wherein the capacity nicotine alleviate the few of the psychiatric symptoms, but however they are going to vanish over a period of time. But the inhibitory effects of the tobacco smoke on the monomonoxidase, they are reported among the ADHD, schizophrenia, and the bipolar disorders. So here the underlying psychiatric vulnerability itself may lead to the initiation of the tobacco use, or else the tobacco use may lead to the psychiatric illness, or else the both the psychiatric illness as well as the tobacco use may concomitantly exist. So, apart from this, the metabolism of the nicotine also is vulnerable. So, CYP2A6 is a liver enzyme which metabolizes the nicotine to the cotinine in the liver. So, there is a genetic makeup. Whoever metabolize the nicotine rapidly, they are at high risk. So, as compared to men and women, so women are the rapid metabolizers. So, that's why they are highly susceptible to develop the dependence, as well as there is the they find it difficult to quit also. So teens are at risk. Why? Because here the brain is still maturing, and it is not a finished product. It is an unfinished product. So teen brains are like the high amount or the high speed cars with a poor brake system. So, although the taking drugs at any age can lead to addiction, earlier the drug use begins, the more likely it will lead to the dependence. This is probably problematic for the teens because areas in the brain that control the decision making, judgment, and self control are still developing, and they are the last to mature, like the prefrontal cortex. And the teens, they are very much prone to take the high risk behavior, including the trying the drugs, and as well as the high novelty seeking behavior is reported. And it is going to affect the developing brain, and it harms the parts of the brain that control the attention, learning, mood, and the impulse control. So here a person, they experiment the tobacco with the because of the impulsivity, and over a period of time it turns out to be a compulsive behavior. So there is the nicotine is toxic to the developing fetus. Tobacco use in childhood or adolescence, 80% of those smokers who begin smoking by 18 years of age, 20 to 25% of them become the adult dependent daily smokers. The risk of dependence increases when the smoking begins early. That's why many of the public health intervention, there is a age restriction for the buying and the selling of the tobacco products up to 18 years in India, though the brain maturation takes place up to 25 years. Every year the substance use is delayed, the risk of developing the substance use disorder is reduced. So here the nicotine addiction, it is not attributed exclusively to the physical addiction, but it is a triangle comprising of the physical dependence factors and the behavioral and the social connections, emotional and the psychological connection. The physical dependence is attributed to the nicotine addiction cycle, wherein a person uses nicotine. Nicotine use leads to the pleasure, enhanced performance, and the mood regulation. But over a period of time, tolerance and the physical dependence develops. So whenever the person tries to reduce or stop, the withdrawal symptoms appear. So in order to suppress the withdrawal symptom, again a person takes the nicotine. So this is how the nicotine addiction cycle continues. Another one is the behavioral and the social connection. The addictive tobacco habit is intimately tied to the user's everyday activities, triggers, or the cues in the environment. So that is the, it may be tied to the time, place, person, and their emotions and the feelings. So here the emotions and the psychological tobacco uses now link the tobacco use with the certain emotions, thoughts, and beliefs. So that by the process of the withdrawal or the operant condition. So reward or the punishment. When nicotine is inhaled, it causes a rapid release of dopamine, which in turn cause feeling of a pleasure that turn the uh, that reward and reinforce the behavior, which makes them to use the tobacco again. So as to get that reinforcement and to drive the process of the addiction. That's why it is very much important. The part of the quitting, whenever we are addressing the tobacco cessation, it becomes very much important to break these subconscious connections, and important to work with the patients to find out the link between the tobacco, their feelings, beliefs that the smokers form, and help them to debunk that the negative beliefs about the tobacco and the quitting. So many of them will have the negative belief is nothing going to help, and I won't be able to quit, and then I'm a happy user, and for in order to perform the task I need a tobacco. So it is very much essential to educate them here. And then in order so as to components of the tobacco dependence to address the physical dependence, NRT pharmacotherapy and the in the form of the NRT and the non-NRT medications are given. To address the psychological, then the pharmacotherapy as well as the behavioral counseling is done. And for the behavioral component, the connection, the behavioral counseling is done. So that's why holistically, in order to address the nicotine addiction, so pharmacotherapy plus the behavioral counseling, behavioral support is the gold standard. So, what is it? So, here the mood, cognitive, and relaxation effect of the tobacco are thought to occur via the nicotine stimulation of the presynaptic alpha 4 beta 2 N acetylcholine receptors, which are situated in the ventral tegmental area. So, whenever a person smokes the or the take chews tobacco or vape, what will happen, especially if a person smokes a cigarette, it hits this pleasure circuit by 10 seconds, and then leads to the release of the stimulation of these receptors and release of the dopamine. So dopamine, not only the release of the dopamine, but other neurotransmitters are also released, which leads to the which give a positive reinforcement for an individual, and they tend to use it repeatedly. So with the release of the dopamine, it leads to the pleasure and the appetite suppression. Norepinephrine is released, which causes the arousal and the appetite suppression. Acetylcholine, arousal and the cognitive enhancement. That's why many of them tie that in order to perform a task, before performing any task, increase the concentration, they need a smoke. Or then glutamate for learning and the memory enhancement. Serotonin, mood modulation and the appetite suppression. Beta endorphin for the reduction of the anxiety and the tension, and GABA for the reduction of the anxiety and the tension. But over a period of time, these the positive reinforcement because of use of the tobacco, it becomes very much, starts diminishing. So nicotine administration, it causes the I told you that these receptors. So with alpha 4 beta 2 N acetylcholine receptors, they are in the resting stage, which are present at the ventral tegmental area. So once the person takes tobacco, this nicotine, it causes the receptors to open. So when these receptor channels are open, what will it lead to the release of the dopamine and the other neurotransmitters. And then what can it lead to? The long term receptor stimulation. So it will lead to their desensitization. So over a period of time, because of the use, what will happen, they become desensitized, and when they are in the desensitized stage, they are no more react to the nicotine or the acetylcholine. So this occurs approximately the same length of times it takes to finish a cigarette. And then as the real problem starts now, as these receptors resensitize, then the initiation of the craving takes place, and withdrawal effect occurs because of lack of further dopamine release. So here, the arousal, mood modulation, and the pleasure, I told you these are the effects they happens. But over a period of time, you see that many of them, that as far as tolerance is concerned, they may start with a one smoke, the one cigarette, they may start with a one chew. Over a period of time, it keeps on increasing, and they may report that they are using it 10 times daily, 20 times daily, like because of the adaptation of this neuro adaptation of these nicotinic receptors. So what will happen, because of the repeated hits of the nicotine hits, these receptors undergo multiplication. So then as the receptor multiplication takes place, in order to get those reinforcing effects, the amount of nicotine to saturate these receptors is also increased. That's why even the number of chew, number of to smoke, that also frequency and the concentration of the nicotine also increases over a period of time to get that effect. So that is a tolerance, and the physical dependence will develop. And then what will happen, if a person reduces the intake of the tobacco, or else avoid taking the tobacco, what will happen, the withdrawal symptoms will start appearing. So these are the physical, psychological, and the emotional unpleasant symptoms, which include the irritability, frustration, anger, insomnia, and then the increased appetite, anxiety, restlessness, impatient, dysphoric mood, and then the difficulty in concentrating. So now an individual will develop the craving. In order to suppress these withdrawal symptoms, they'll go for the next smoke or the next chew. This is how the nicotine addiction cycle take place. So this severity of these withdrawal symptoms, so they are going to last for about peak or for about first initial 3 days, at the first 15 days also you can consider, and then comes you're going to last for about 12 weeks, and the peak relapse is also like up to the 10 weeks, and there is increase in the appetite and the weight gain is there, and the craving lasts for about more than 12 weeks. So, what is nicotine dependence? According to the ICD, like 11 DSM-5, it is a disorder of regulation of nicotine use arising from the repeated or continuous use of the nicotine. The characteristic feature is a strong internal drive to use nicotine, which is manifested by impaired ability to control its use, increased priority given to use over other activities, which is called as salience, persistence use despite the harm or the negative consequences. These experiences are often accompanied by a subjective sensation of urge or craving, intense urge to use the nicotine. The physiological features of dependence may also be present, which include the tolerance to the effects of nicotine, withdrawal symptoms following the cessation or reduction in the use of nicotine, repeated use of nicotine or pharmacologically similar substance to prevent or alleviate the withdrawal symptoms. So, that in order to call a person is dependent to the nicotine, then you should be evident for a period of at least 12 months, but the diagnosis may be made if nicotine use is continuously daily or almost daily for at least 3 months, presenting with the characteristic features of loss of control, persistent desire or unsuccessful efforts to stop using, craving, failure to fulfill the major obligations due to use, greater deal of time spent obtaining, using, and recovering from the substance, continued use of the substance despite having the social interpersonal problems caused and made worse by its use. Important activities are reduced or given up because of the use. Substance use in situations where it is physically hazardous. Continued use of the substance despite having physical or psychological caused or made worse by the use. Tolerance and the withdrawal. So, what is the dentist's unique role in tobacco cessation? So, here at we, the dentists, like more often, have a regular contact with the patients of all age groups. In fact, our role starts before our birth itself, because even we address a pregnant woman. So, here we are the first to see the effects of tobacco in the mouth. So, we are in a perfect position to give the feedback of its use, which are seen as an initial manifestation of the tobacco use. And this is where the opportunistic screening of tobacco induced oral lesions could be done. So, like that, we had to utilize these teachable movements and utilize the dental chair side time for every patient who visit us during their every visit, and ensure the documentation and record it as a fifth vital sign whether the person uses a tobacco, which form and how frequently and how long he have been using. So, like here, and we are the dentists, we are the only health professionals who frequently see the healthy patients. I mean to say, we come across the patients who are the conscious, oriented to time, place, and the person. So, we are in a position to sensitize the patients of tobacco use and impact on the dental treatment outcomes as well. So, we are in a reinforce the anti-tobacco message, as well as being able to motivate and support the tobacco users who are willing to quit, and recommend non-tobacco users to never start, and address the follow-up and schedule well. Since many of the dental procedures are like based on the multiple appointments, so every appointment we have to reinforce the anti-tobacco message and do the regular follow-up and schedule well. And we had to, in fact, even explain them about the total economic cost or the attributable to the tobacco use. Brief interventions. These are the practices aimed at investigating a potential problem in a short interaction, motivating an individual to do something about it. So it focuses on the enhancing the tobacco users' motivation to change and connecting them with the evidence-based resources so as to make their next quit attempt a successful one. So here it comprises of the 5 A's: ask, advise, assess, assist, and arrange, and 5 R's model: relevance, risk, rewards, roadblocks, and the repetition. So if we don't have time to do that, then at least what we can do: ask, advise, and the refer. So we had to ask about the tobacco use, we had to advise them about the to quit the tobacco, and we can take the help from the externals, refer them to the tobacco cessation specialist, counselors, medical professionals, if at all they have the comorbidities of the physical as well as the psychiatric. And ask, advice, connect to help the patients to quit through the you can external resources. Either it may be an M cessation program, that is quit tobacco for life, by giving a missed call to number like 01122901701, or then or they calling the national tobacco quit line numbers 1800112356. So ask. So what I have to ask about the tobacco use at every visit. Ask about the tobacco use status, whether they are the current users, former users, or the never users. Amount used, whether daily and the weekly. And if they are not, say that they are non-smokers, you have to ask about the exposure to the second-hand smoke as well. Does anyone around them use the tobacco? and then which type of the tobacco product is used, how often they use, tobacco use patterns, and the attitudes. So what led them to the initiation of the tobacco, and what are the maintaining factors, and what is their do they have any recent quit status of less than 1 year, and then you had to assess the challenges, confidence, and they need the support. And then comes the advice every tobacco users to quit in a supportive and non-confrontational way. So do not like fear arousal doesn't work here. We have to give a clear, non-judgmental, strong, personalized advice to quit, and connect the advice with the oral findings, which are very much visualized. This we can give the visual feedback. So, for example, personalized, if you want to give an advice, it could tie the tobacco use to the current health or the illness, significant life events, social, economic cause, motivation level, readiness to quit, or the impact of the second-hand smoke on children and others in the household. So, the one example would be, I know you are concerned about your cough and that your son gets many colds. If you stop smoking, your cough should improve and your son might get fewer colds as well. So you had to assess the patient's position in the stage of the behavioral chain, motivation according to the Prochaska and Declement's model, and you had to evaluate the client's change readiness at every visit. So here it is comprised of the pre-contemplation. So pre-contemplation are the those who are in the pre-contemplation are the happy users. They're not thinking about quitting, and they are unaware of the need to quit, and maybe very much resistant to the behavioral change. So our action step, so whatever the actions based on the behavioral stage where they are in, our intervention should be focused. Here our action should be focused on changing their knowledge, enhancing the motivation, using the 5 hours and the motivational interview, and then the inform the patient that you are available for the support if they want to quit in the future. Then comes the contemplation, that is thinking about quitting within the less than 6 months, but here the ambivalence is very much evident, whether to quit or not to quit. And then here, but they are not ready to quit. So benefits of use still outweigh the costs of quitting. So here our intervention should focus on the changing their attitude, and enhance their motivation by the motivation enhancement therapy, and answer the questions and provide the support if they need. Then next comes the preparation. Here they're ready to quit in the next month or the next 15 days, and may begin and even they may try to reduce the tobacco use also. So our we should help them to patients to create a quit plan, prescribe if they require any medications to quit. So we have to ask them and assist them in here. And then comes the action stage. Here those that support the patient, they are quit the tobacco, recently quit tobacco but less than 6 months, they're successful in remaining abstinent for 24 hours to less than 6 months. Our intervention should focus on the support the patient during quit attempt, and if still abstinent, we have to congratulate them and reinforce the strategies to be successful. So this is where even our like the repetition or the like follow up is very much essential. If the relapse occurs, do not discourage them. So they had to reassure the patient that the lapse and relapse are the part of the journey, and then of quitting the tobacco, and discuss any modification, what worked and what did not work, and if at all any modification has to be done in the quit plan, do it accordingly, and reassess their stage of change may be very much essential. So here next comes the relapse. It is a step backward from any stage to the stage 1 to 3. So here next comes the maintenance phase, wherein successful quit attempt for more than 6 months. So here they can be the most difficult stage to attain, and it working to prevent relapse and continue the behavioral change. Though you had to congratulate patient on their success, and we had to continue to monitor the tobacco use status, provide the relapse prevention strategies, and the support whenever it is required. Assessing the nicotine dependence severity is best. So we have the certain scales we most commonly use Fagerstrom test for nicotine dependence, both for the smoking as well as the smokeless form. So the six components are there which assess the severity of the components of the dependence. But the best measure is the number of the cigarettes or the chews per day, and time to first cigarette or the chew upon awakening, measuring the physical dependence and intensity of the withdrawal symptoms after the overnight abstinence. So these items, both the items are used for dosing the NRT medications. But however, this has a limitation. It does not capture the psychosocial and the behavioral dimension of the nicotine dependence. So you had to assist in the quit attempts. So here, like, uh, tobacco cessation phases and the strategies, the phases which lead to quit attempt, person is preparing to quit. So you had to help them to set a quit date within 30 days. You had to go for the star strategy. And phase after quit attempt, when a person is in the action stage, you had to tell them about the avoidance of the triggers and the relapse prevention. And to maintain the quit status, they had to assist them in maintaining the sustain the behavioral change. So helping the patient with the quit play, here we are helping assisting a person to transit for a smooth transition from the old behavior to the new behavior. So here, like, the we had helping a patient to with a quit plan, that is a start as a strategy, discussing with them the potential withdrawal symptoms and the triggers with the coping strategies, provide the practical counseling, problem solving and the skills training, and stress management and relaxation strategies. Intra treatment and the extra treatment social support and the family support is very much essential. Provide the self help material, tips to control the cravings, recommended use of the pharmacotherapy, and the referral to the further assistance. So what is this STAR strategy? So S stands for acronym STAR. The S stands for set a quit date. Ideally, the quit date should be within the 2 weeks. Total abstinence never, not a even a single puff or chew after the quit date. And T stands for tell family, friends, and co-workers about quitting. Request understanding and support. And anticipate, A stands for anticipate challenges to the planned quit attempt. Nicotine withdrawal symptoms, they are critical at first few weeks. Craving, peer pressure, stress, intrapersonal and interpersonal stress, and the emotional states. So then R is to remove the tobacco products from your environment. So access denial. So prior to quitting, avoid smoking in places where you spend lot of time. Example, it may be in the car or else in the park or else with the home. So nicotine withdrawal. So it is clinically significant cluster of symptoms, behavioral, physical, physiological features varying the degree of severity and duration that occurs upon the cessation or reduction in the use of the nicotine. So like it may present with a dysphoric or depressed mood, insomnia, irritability, anger, difficulty in concentrating, restlessness, bradycardia, and the increased appetite and craving for tobacco, increased cough and mouth ulceration as well. So, in order to meet the diagnostic criteria of nicotine withdrawal, the following must also apply. Symptoms cause clinically significant distress, and these distress are not due to any other condition. Other conditions like the general medical condition are not accounted for by any other medical disorder but exclusively attributed to the nicotine withdrawal. So, what are these triggers? These are the triggers of the condition cues. These are the places, things, times, emotional states associated with the use of the tobacco with the client. So, where they use the client, when they use, what they were doing at that time, with whom, what was the expectancy. These things need to be very well addressed. So, the common tobacco use triggers are feeling stress, feeling sad, talking on the phone, drinking alcohol, taking a work break, seeing someone else smoking, to cool down after a fight or an argument, feeling lonely, drinking tea or coffee need to relax. So many of them report the first eye opener would be the on the toilet seat, so as to for the smooth passing of the stool. So many of them will have a early morning craving to go for a smoke or the chip. So, common elements of effective counseling, we had to focus on the dangerous situation. We had to educate them about the 3Ds and the problem solving skills. Dangerous situation, identify, develop the coping skills, discuss and provide the information. So, they had to know about the triggers or the cue, what they have, and how to cope with them, the coping skills. So negative effect, how to cope with that, being around the other smokers, what are the coping skills, drinking alcohol, experience the urges, being under time pressure, how they are going to handle them. So then comes the coping skills, learning to anticipate and avoid the temptation. So they know that they are going to have get the craving there. So they need to be taught about the how to avoid the craving. And cognitive strategies that reduces the negative mood. Lifestyle behavioral and lifestyle changes is the most common essence which improve the quality of life and produce the pleasure. Alternate pleasurable activities and learning cognitive and behavioral activities to cope with the smoking urges, and discuss and provide the information, not even a single puff. And withdrawal typically peaks 1 to 3 weeks after quitting, and addictive nature of smoking need to be explained. The tips to control the cravings: it begins 6 to 12 hours after stopping the tobacco, and it is at its peak for 1 to 3 days and lasts for about up to 3 to 4 weeks. As the day pass, the cravings will get farther and farther. So here we need to educate an individual that they have made set up their mind to quit tobacco. So every time whenever they get a craving, that they need to remind that they have made a decision to not to take a tobacco. Rehearse. They know that this trigger is going to anticipate this thing, coping skill, they need to be rehearsed with that. And reward, yes, I did not smoke, so they need to reward themselves. However, to handle the nicotine withdrawals and the craving management, so the D's like the delay. Delay the tobacco use, distract, do something else, deep breathing, drink water, don't just have one, that is a zero puff rule. Discuss with the family and the friends, and say explain them that you have made a decision to quit tobacco. And if at all a support is required, approach the healthcare professionals to go for the any NRTs and the non-NRT medication, and call for help, because the national tobacco quit line numbers are available, they are free. And then they can call to the national tobacco quit line number 1800112356, or connect to the M cessation by dialing to the giving a missed call to 01122901701. Avoid the triggers and remind yourself of the benefits. So quitting tobacco, which is unique for tobacco, smokeless tobacco users, that is oral gratification. Missing something in the mouth, strong need for oral substitutes, chew, snuff for the pouch. So then these we need to substitute. Then change in the lifestyle is an essence. So now we have a trigger, and then the routine was associated with the use of the tobacco and the reward they had got because they had experience. Now we had to replace the routine with the alternate pleasurable activity. So then comes the new skills and behaviors need to be active, need to be practiced. And then the start a activity that occupies their hand, stop drinking alcohol or the caffeine, which were in the paired behavior, like they link with smoking and the alcohol, and then the smoking and the tobacco, this coffee intake. So if we cut down on one, then other should also be paired behavior, that also should be avoided. And relaxation technique and visualizing themselves to be a non-tobacco user. And the earth surfing, so here like the rather than giving into a craving, you can ride it out like here. So like a surfer, motivated surfer, like riding a wave. So you know that there is a particular trigger, you're going to get an urge to use the tobacco, so it is going to rise, the craving increases and becomes so strong. When you wait and you till it reaches its peak, the powerful point, delay, this is where the delay distract, and then you know that it is going to fall. The fall, there is, it reaches its peak, and they are going to like a strong motivated you're going to surf the urge. So this is called as earth surfing. And avoid the few of the triggers like the hunger, anger, loneliness, tiredness, and the boredom. So discuss the past quit attempts, what worked and the not what did not work. Choose a cessation method accordingly. Non-pharmacological strategies, whether they want to go for the gradual tapering or the cold turkey, or do they require any of the pharmacological methods. So as far as the NRT medications are concerned, we have the NRT gums, NRT patches, and then the NRT lozenges available in India. And as far as the non-NRT medications are concerned, varenicline and the bupropion have got the more effectiveness. And then like this dosage and all, everything is explained here. And arrange for the follow up. So follow up is very much essential. So it is like the initially the timing of follow immediately once they set up a quit dated 1 week, 1 month, 3 months, 6 months, and up to 1 year they need to be followed up. And action during the follow up contact. So like document the tobacco use status and the intervention status, what happened for all patients, identify the problems which are encountered, anticipate the challenges, remind for extra social support, assess medication use and the problems, whether they had any problems or the any adverse effects they had faced, and patients who are abstinent, congratulate them and review the challenges and give relapse prevention tips. And patients who are relapsed, remind to review relapse as a learning as a part of the journey, and link to the, if at all they have any of the psychiatric comorbidity or anything which are act as a roadblock, please connect to the other healthcare professionals. And those who are not willing to quit the 5 hours model, why it is relevant, how is quitting most personally relevant to them, whether it may be the health related, physical, psychological or the social. Then all forms of tobacco and nicotine products are deadly. None of the forms of the tobacco are safe. And as far as smoking is concerned, like there are more than 7,000 chemicals are there, and more than 70 carcinogens are present. And then smokeless tobacco contains more than 3,000 chemicals and the 30 carcinogens. So here, like the nowadays, the new challenges with the new or the novel products. So here, the tobacco industry realized that because of the more stringent tobacco control measures, than people quitting the tobacco or those who are dying because of tobacco use, so they started targeting the replaceable customers for their uh, to so as to make their industry to run. So here, like the adolescents or the youths are the one there, they're the target customers. So they have a rhetoric that the novel products are safer. They market that there is matrix of reduced risk nicotine delivery system. They attributed the harm is due to the combustion of the cigarette. That is the most harmful way. So if you use this matrix of reduced risk nicotine delivery systems, that harm is avoided. But however, you have to, if you see the continuum here, so likely least harm are the medicinal nicotine, electronic cigarettes, smokeless tobacco, and the most harmful is the combustible one. So you have to remember the few points that the smoke-free products are not risk-free. So here that they're the nicotine-based products, they're the heated aerosol products, that is vaping products. The generations are there. Like then comes the heated tobacco products. They heat not burn devices. They're marketed as I quit ordinary smoking, and oral nicotine products that then the snus pasteurized tobacco, so they were marketed to be safer products. But smoke free products are not risk free and are addictive. The best choice is one can make is to quit cigarettes and nicotine completely. So here the tobacco industry, what happens eventually, a person because of this, that is it is harmful to health and harmful to the people around them, they may switch to the vaping. Ultimately what happens, the person will continue to smoke also and vape also. So here the you will find the dual users. So here vaping is less. We had to remember few points. It is less harmful than, but it's still not safe. That is, uh, e-cigarette and vaping associated lung injuries have been reported. And CDC recommends do not use THC containing the vitamin E. Avoid using informal sources where they're going to refill or the customize the vaping devices. Do not modify or add any substance to vaping device. Research vaping is bad for your heart and lungs. What are the risks? So acute risk, long term risk, and the environmental risks are concerned. As far as for the tobacco oral health is oral dental use is concerned, so it is like the use of the tobacco has got a person who uses tobacco is at 5.6 time of risk of developing the oral cancer and leukoplakia, and 2% risk of twice the risk of developing the periodontal disease, and tooth loss 1.5 times. And even the passive smoker is also has an estimated odd of 1.2 percent of developing the periodontal disease, and the risk of developing dental caries is 1.7 times more than that. So, long term adverse health effects, if you see the clinical morbidity and mortality, it affects the middle and the late adulthood, leading to suffering, impaired quality of life, and the death. And tobacco use is linked to the 20 types of cancer, and lifelong tobacco user lose at least 10 years of their life on an average. And then it is called, if a person claim that I am a light smoker, still they are at risk of the developing the cardiovascular disease, clinical CVD endpoints, stroke, abdominal aortic aneurysm. And then again the second hand smoke exposure, so the person the child may develop the frequent lung infection, middle in ear infection, and if a pregnant woman, the seeds, and then the preterm delivery risk is also there. So, what are the immediate health effects of a pregnant woman smoke? So, for both men and women, it affects the fertility rate. Even to risk, it affects the PCOC problem is there, and then the risk, the chance of conceiving is reduced, and then the low sperm count and erectile dysfunction is very much evident among the men, and then the likelihood of becoming pregnant is reduced among the women, and pregnancy complications and ectopic pregnancy, shortened preterm delivery, and outcome of the childbirth and survival, that may be the sudden infant death syndrome is very much evident. Low birth weight baby, congenital malformation, especially the orofacial clefts are there, and then the impaired reduced lung function. So, what are the rewards? So, these were the risks. So, there are the rewards of quitting tobacco as well. So, which are going to start with the immediately 20 minutes after quitting to the like over the over years also. So, here if a person the 20 minutes after quitting, the heart rate and the blood pressure drops to normal. 1 year after quitting, the coronary heart disease half that of a smoker. 5 to 15 years after quitting, the risk of stroke is that of a non-smoker, and after 10 years of quitting, risk of dying from the lung cancer is halved, and then 15 years of quitting, risk of coronary disease and fall to a non-smoker. 1 to 9 months after quitting, coughing and shortness of breath decreases, and 2 weeks to 3 months after quitting, the circulation and the lung function improves. And as far as our oral diseases are concerned, if our cessation benefits are there, if the 5 years after quitting smoking, the risk of developing oral cancer is cut to the half, and quitting smoking and smokeless tobacco can reduce the risk of developing the leukoplastic lesions, and periodontal disease also risk of developing them reduces, and melanosis, halitosis. So there are certain benefits are there which we need to relink with the patient's oral health status and give them the rewards of quitting the tobacco. Then what are the roadblocks? So here the the roadblock may be the underlying like lack of individual link to the individual and the lifestyle, physical addiction, behavioral habit, and the low self confidence, failed past quit attempts, cognitive benefits, and then the combating the loneliness, autonomy. So then social and the community, that in order to socialize, and then the social lack of social support from the healthcare professionals, high prevalence and accept, that is normalized behavior, living and working condition, if they're under stress, living work and where they're with people who use the tobacco around them, and the cultural and socio-economic and factors, that is a cultural norm. So if they share this, that is sharing of hookah, sharing of tobacco products is related to the socio-cultural bonding also. So the roadblocks, like clinicians should ask the patient to identify these barriers and impediment to the quitting and address them with the problem solving counseling and the medication. Repetition, I told you like why it is important. So here, for your patient want to be a non-tobacco user, she can quit the, please focus more on the roadblocks, and then the, if a patient doesn't want to be a non-tobacco user, please focus more time on the risks and the rewards. And then if a patient is not ready to quit completely, like at least you should help them in the tapering the things. So relapse prevention. So we had to assist the people to avoid or cope with the high risk situation for tobacco use. Red flags from occurring it from a full relapse. Identify the high risk tobacco use. Manage the cravings. Dealing with the faulty ignition. Plan the coping skills in advance. Handling the high risk situations. Emergency plan to deal with a slip to prevent into full relapse. Coping tips need to be taught. Then the dead pointer technique, that is deliberately delay or act of lighting up a cigarette or do by something else. Escape from the situation. Avoid, plan to avoid the situation where there is risk of tobacco use. Distract yourself from the tobacco use through the alternate relaxation techniques with the or else with the family. And the tobacco refusal skills need to be taught, and then like the change the subject, say no firmly, use the humor, give the reason, provide other options, leave the situation and tell a story. So this I am just giving you where in the tobacco use like feedback, like voice of the tobacco victim. So this is one of the public health program where it was conducted for the drivers association. So wherein they were taught about the oral cancer self examination, if they were using to identify the indicators of the tobacco use in the oral cavity, and they were educated about how to connect themselves to the, if they seek any help to the using the app as well, the WHO to quit tobacco app, and to connect them to the quit line numbers. So effectiveness of methods to treat tobacco dependence. The best method, like here, like we have the Cochrane evidence, that is the high certain evidence that using combination NRT, fast acting form, that is in the NRT in the form of the gums, lozenges along with the patch, is more effective than giving the single no, long single form of NRT, which increase the chances of quitting successfully. And then as far as the counseling is concerned, the group counseling that has got the highest evidence, that is 1.8 times, and then the chances, and compared to the brief counseling also has got the person who where brief counseling intervention is also effective, 1.8 times improves the outcome of cessation. And as far as the first line pharmacotherapeutic agents are concerned, so here the varenicline has got the highest efficacy. It doubles or triples the chances of quitting the tobacco, and then the followed by the here the inhaler and the combination RT, as well as the bupropion sustained release. So, quitting tobacco nicotine products, role of healthcare professionals. It is a chronic disease that often requires repeated intervention, multiple attempts to quit. Tobacco users remember that they need help to quit, and then those who try to quit on their own, so only 1.1 to 3% of them remain abstinent for a year, and intense abstinence rate is only 20% or less. And here, like most smokers make 5 to 10 attempts, 50 of them may become successfully abstinent, and most tobacco users want to quit. This is where the gap really arises between the need to they seek help to quit the tobacco. The professional support and proven cessation medication double the tobacco users' chances of successful quitting. So, engaging a tobacco user starts with one simple question: do you currently use tobacco? So, many people want to quit. Let's being a oral healthcare professionals. So, like lend our support and to quit the tobacco. So here the many of the clients want to quit the tobacco by the participation of the healthcare providers in the tobacco cessation is less. So we can always boost the offering help to quit tobacco through the tobacco cessation skills, and be a game chamber in our practice, routine dental practice. So we have to encompass even the tobacco cessation should be an integral part of the dental care treatment. Thanks a lot. These are all my references.
Thank you, Dr. Aruna, for that wonderful presentation. I think you need to turn your camera and mic on. Okay, while she does that, let me share some. Okay, she's here.
Yes, she's here.
Okay,
Okay,
right.
right.
So
So
let me check
let me
that there
check
is
that there is
no.
no.
I think there's
I
still
think there's
a.
still a.
Yes, there is
Yes,
still
there
a
is still a
feedback from my
feedback from
side.
my side.
1 minute.
1 minute.
So
So
you can answer
you can
this
answer
question
this
in the
question in the
meanwhile from
meanwhile
Dr.
from
Amit
Dr. Amit
Dalmia.
Dalmia.
I will turn
I
off
will
my
turn off
mic
my
and I will
mic
take
and I
care
will
of
take
this.
care of this. Yeah, relative risk of oral cancer, no?
Yes, the question
Yes,
is
the
down there.
question
You
is
can
down
read
there.
it
You can
out.
read it out. Yeah. Yeah, thanks, Dr. Amit, for raising this query. So, as far as the tobacco related oral condition and the health risk associated, especially the oral cancer, the smoking is 5 to 10 times more likely to develop oral cancer than the non smoker. And in the Southeast Asia, especially where the smokeless tobacco youth, three-fourths of the smokeless tobacco users reside, they are at 5 times more likely to develop the oral cancer. And actually the smoking Tobacco plus alcohol, actually, again, the risk is higher. And as far as the IRC is concerned, so again the arecanut also adds the group 1 AI carcinogen, because in Indian subcontinent most oftenly, like they use the tobacco, pan, betel quid, and the lime mixture. And alcohol, like actually, especially tobacco, alcohol, poor oral hygiene, so they it increases further the risk of the oral cancer, especially the floor of the mouth. So the pool, this is at the, they are at the approximately 5 to 6 times risk, higher risk of developing the
Right.
oral
So
Right.
let's
cancer. So
try and
let's
see
try
if
and
my
see if
voice
my
is
voice is. Ma'am, you are audible.
okay, but I
Okay,
think
but
there
I
is a
think there
lot
is
of
a lot of
feedback still,
feedback
no?
still, no? Yeah.
Do you
Do
have
you
anything
have
else
anything
on
else
at your
on at
side?
your
Is
side? Is
YouTube also
YouTube
on
also
at your
on at
side?
your side? No.
Or do you
Or
have
do
two
you have
different,
two different,
the browser is
the
open
browser
on two
is open
different
on two
tabs?
different tabs? I'm not audible, what, ma'am?
Okay. Anyway,
Okay.
so
Anyway, so
no, your voice also
your voice
is
also is
echoing. So
echoing. So
I have already
I have
checked here.
already
So the
checked
only
here. So the
other
only other
possibility is
possibility
that
is that
there is a
there
feedback
is a
from your
feedback
side.
from your side. Okay. So as far as the risk factors for oral cancer is concerned, so it is, oral cancer is a preventable disease of multifactorial etiology. We know it, and according to the IARC, like we have the sufficient evidence for the tobacco smoking form of tobacco, but however there is a gap in providing the inadequate evidence as far as the smokeless tobacco is concerned, which is very much evident, wherein our nearly the 21.8% of our Indian adults use the smokeless tobacco. So there the gap is there. So we need to provide sufficient evidence for that. And arecanut also, like including betel quid with or without tobacco, has a sufficient evidence, and the alcohol consumption also. And the lack of oral cancer awareness, and then the, so since this is a one of the preventable cancer is preventable one, and wherein the 60 to 80% are attributed to the use of the tobacco. So we being dentists, like, and we as far as like uh, we need to address the tobacco use for every patient and ensure the documentation as well.
Okay, since we
Okay,
are
since we are
not
not
able to
able
sort
to
out the
sort out the
problem, I will
problem, I
just
will just
bring the
bring the
question here. You
question here.
just
You
read it
just
and
read it
answer
and
it,
answer it,
please.
please.
Can you read the
Can you read the
question on the
question on the
screen?
screen? Yes, ma'am. Yeah,
Okay,
one
then
more
just
Okay,
read
question
it
then
and
just read
answer
it
it,
and
please.
answer it. Yeah, yeah, I'll do that. So there is one more question on the arecanut actually. So according to the IARC, like it is a group 1 carcinogen, and it is established, and the arecanut causes cancer of the oral cavity, pharynx, among the multiple other sites, and cessation of uh, and then because attributed to the arecolin, arecadin, and guacolin and the guaicin, and these are the major alkaloids which are present in the arecanate, and arecolin dependence scale is also used. So the risk of dependence also increases if they combine the use of the tobacco as well as the arecanate.
Right.
Right.
So,
So, so like one more, what about the other additives in cigarettes? Yes, like menthol and other things they add in the cigarette also may increase the, and then even the pH part also. As far as cigarette is concerned, the reduced pH facilitates its absorption. But for a smokeless tobacco, the increased pH facilitates absorption in the oral cavity. So the kick they get, no. So because of the bigger in the uh, uh, lungs and all, the low pH will facilitate its absorption. Whereas in the oral cavity, you see that the tobacco lime mixture is there, and nicotine is a weak alkaloid. So usually we see that in the smokeless tobacco they add the lime so as to increase its pH and facilitate its absorption through the oral mucosa.
okay. Right. So, you
So,
see
you
any more
see any more
questions?
questions? This like patent rights on your presentation? No, sir. Like this actually, yeah. What about the role of Zyban assisting the patients? So Zyban is also again like so if sir is there, like I want him to comment on Zyban actually. So Zyban has got a very good evidence of the that's nothing but the bupropion hydrochloride, and 150. It has got a very good evidence. So like it has got the antidepressant effect as well. And when bupropion hydrochloride combined with the nicotine gum or the lozenge, that this is where the combination NRTs. So along with the bupropion, if it is given, it has got a very good evidence actually. But only thing we had to take the caution that the person does not have any seizure episodes. And here, like initially, it has got a very good evidence that that is a bupropion hydrochloride and varenicline. Like they have got very good evidence. And in order to have address the breakthrough cravings, if we give along with the NRT gum or the lozenges, it will be more effective. Because of the time constraint, I couldn't cover everything in detail, so that's why I just explained this in the summary of evidence part, the chart.
Okay.
Okay,
So,
so
I really
I
don't
really
feel like
don't feel like
talking.
talking.
Okay.
Okay,
So,
so
let
let
me
me
1 minute.
1 minute. But
Right.
anytime, like we need to address both the physical dependence, the Zyban, Varenicline, NRTs, they'll take care of the physical dependence. But the behavioral support is very much essential. Because in the nicotine addiction triangle, so it is not merely the physical dependence but the behavioral and the social connections as well as the psychological connections need to be addressed. So many, because many of them as they develop the dependence over a period of time, they'll be having even few of the psychiatric conditions also, so they which may remain as a roadblock.
Okay.
Okay.
Can you hear me
Can you
now?
hear me now? Yeah, ma'am.
Right.
Right.
Has
So
the
you can use
echoing
a
become
simple
better?
become better. Yeah, the simple screening like patient health questionnaire could be used to identify the depression and the thing, and the few of the psychiatric symptoms also could be assessed actually. Whether they have the anxiety related issues, depression related issues, because they always would underlying psychiatric disorder would be a roadblock. No matter how much they pop the lozenges or the this thing, NRTs, and they put the patch, it won't work.
Okay,
Okay,
so I
so
think
I
we
think
can
we can
just,
just,
there are
there
no more
are no more
questions now
questions
from
now
what I
from
can
what I can
see.
see.
Thank you
Thank you
everyone for
everyone
being
for
with
being with
us.
us.
I am
I am
so sorry
so
for
sorry
this
for this
sound
sound
problem.
problem.
I'm not going
I'm
to
not going to
speak
speak
anymore.
anymore.
I'm just
I'm
going to
just
show
going to
you
show you the
the next two
next two
programs,
programs,
and then I'm
and
going
then
to
I'm
go
going to go
on to
on to
the
the
certificates.
certificates.
There's one question.
There's one question. Yeah.
Can you see the question, Dr. Aruna?
So along with the
Can you
see
see
the
the
question?
You
Yeah,
can
yeah,
just
yes.
answer it,
Do you recommend use
please.
bupropion in conjunction with the nicotine substitutes? Yes, sir. Like it could be because if they have the intense craving, and then more of the like oro hand to mouth rituals, so that this long term NRTs or else this non NRT medications may not help. So for them, in order to like have a better outcome, so in order to address the breakthrough cravings, a gum or a lozenges could be given.
Okay.
Okay.
Right. Thank you so
Right.
much
Thank you so much
for being with
for
us for the
being with
presentation,
us
which
for the
was very
presentation,
thorough
which
and
was
well
very
done.
thorough and well done.
Okay. I'm sorry
Okay.
for this.
I'm
I'm
sorry
going
for
to just
this.
end
I'm
now.
going to just end now.
Bye bye. See you
Bye
all
bye.
next time.
See you all next time.
Bye. Thank you,
Bye.
Dr. Aruna.
Thank you,
Bye.
Dr. Aruna. Thanks, bye. Ma'am.
Bye.
Bye. Bye.